This is the second part of our class on acquired disabilities, rehabilitation models, and issues. This PowerPoint was created by Frank McDonald and was adjusted to this class. We will mostly talk about management, self-management, and psychosocial strategies. If an individual expresses suicidal ideation, we have to ensure a person's immediate safety. They have to obtain an urgent psychiatric consultation if person's immediate safety is at risk. We need to determine appropriate setting of care and treat underlying problems such as depression, substance abuse, pain, and so on. Management also needs to involve family and friends wherever possible. We need to observe the person. That is really important, regular observation. And also what is important is active listening by staff. Management also covers encouraging expression of feelings and encouraging active coping, and also helping with maintenance of health, such as hygiene, nutrition, bowel and bladder movement. And there are health problems while the person is in the depressed state. Management of acute stress reaction should involve referral to GP, psychologist, psychiatrist for assessment, normalizing reaction, encouraging the person to talk, time and social support. Management of suicide. We need to ensure immediate safety. We need to ensure psychiatric consultation if necessary, involving others, such as family and friends where appropriate, using active listening skills, encouraging feelings and active coping of the person. This second part of the PowerPoint is on psychosocial intervention and self-management strategies that can help a person deal and cope with acquired disability. Patients who adopt a self-management approach to augment professional management, they fare better with their condition. Subjective experiences like degree of suffering, emotional components of pain usually diminish. Self-management skills include self-education, learning as much as possible about the condition, becoming an expert at understanding and managing pain. Also adopting an internal locus of control attitude, open, experimental, and I control me, not it, pain, or they, doctor's attitude. Self-management skills also include extending coping and self-caring skills, balancing relaxation, mental, physical, and behavioral skills with activity, facing movement and occupation. The following slide includes a picture and graphically illustrates important place of self-management. Higher level treatments tend to be less effective if there are problems at lower levels, so keep that in mind. So here's the pyramid. The pyramid approach that most specialists recommend. You need to start with the basic important therapies, often with patient as self-manager. Response to higher level therapies if needed, rely heavily on those below. Self-management skills are foundational, are a foundation of arthritis care, for example, if we take arthritis, which is a chronic illness. So at the bottom of the pyramid, we see education, exercise, coping skills, diet, and also aspirin. Higher up, there's physical and occupational therapy, non-steroidal anti-inflammatory medication, adapted equipment, and emotional support. Higher up, towards the top of the pyramid, there's surgery, disease-modifying medications, and at the end, HSS, arthritis management pyramid. So these are some management and self-management strategies. So first, deal with the bottom ones, and when these are satisfied and fulfilled, then we can move on higher. There's many psychological strategies that help people cope with acquired disabilities. Anxiety management is one of them, coping with worry strategies, coping strategies for symptoms of disease, such as sleep-wake psychotherapy, increasing either mastery or pleasure activities to at least one per day to counter self-esteem and mood problems, Cognitive therapy for distortions that can aggravate depression and other emotional responses to acquired disabilities. Stress management, often within support group framework, especially for conditions more aggravated by stress, such as epilepsy, pain, respiratory, gastromuscular, skeletal conditions. And social support sessions with family and friends, active listening by leaders. Disclosure therapy, writing and talking about most stressful or traumatic events. Non-directive client-centered group therapy. Corrective information, many anxieties born of misinformation. Further, there are pain coping skills, guided imagery for symptoms for symptom control, attention refocusing when the stimulus is outside of body, dissociation such as self-hypnosis, meditation, self-encouragement with self-reward contingencies, communication skills training, assertiveness training to improve communication with healthcare professionals, carers, and workmates. Further, there are psychological strategies such as enhancing self-efficacy, which is the opposite of helplessness, and learning optimism, increasing appropriate movement, walking, swimming, physical exercises via behavior, connecting, and reinforcement contingencies. And finally, we need to teach significant others to reinforce positive pain behaviors, such as self-massage, and ignore the negative, such as groaning, and relapse prevention to preserve behavior at the juvenile game. For example, there may be groups for maintenance of treatment games.